welcome to this episode of Banner Health's Making the Round podcast. I'll be your guest host for this episode. My name is Jake England, and I'm here to talk to two of Banner's great orthopedic specialists, Dr. Ryan Neeley, orthopedic surgeon, and physical therapist Jake Bowyer. For this episode, we're going to be talking about joint replacement surgeries, what to expect before, during, and after. So, Dr. Neeley, how long have you been an orthopedic surgeon and working on shoulders and elbows?
So I've been at Banner for almost 2 years now. This is where I started my practice. So just a little more about myself. So I grew up in Utah, and I did my training at Brigham Young University, or my undergrad at Brigham Young University. I was playing football there, and I was going to be an entrepreneur, and didn't know what that meant, but I thought they made good money, and I liked Shark Tank, so I was going to be an entrepreneur, and finished my business degree, but I got injured playing football there, and spent a lot of time with our team doctors, and really enjoyed what they did. I thought it was pretty cool, so I spent some extra time with them on the side and decided to go to medical school with plans to be an orthopedic surgeon. So in my training, I did my orthopedic training in Columbus, Ohio, and had a really great mentor who was a shoulder surgeon, and had a lot of fun with him. And I noticed that most of the patients with shoulder surgery in general did pretty well, and I liked that. And I really liked shoulder replacements. The patients got better really quickly, and it was just fun to see them in the office and how quickly they improved. So I then did a 1-year shoulder and elbow fellowship in Tampa, Florida, and was able to spend time with one of the really big minds, especially in shoulder replacement, and he kind of designed some of our modern reverse shoulder replacements and had a great experience. So then I joined practice here about 2 years ago and have really focused my practice on treating, patients with shoulder and elbow disease. So.
That's awesome. And Jake, what got you into physical therapy?
So I got into physical therapy. I actually broke my leg my freshman year in college. So I was playing baseball in Kansas, and I actually collided with my center fielder while playing second base. Had a closed fracture, but they had to do what I had compartment syndrome. So they basically had to do a double fasciotomy on my leg. And then I went through 6 months to a year of rehab, and that actually piqued my interest. Plus, I'm not smart enough to be an orthopedic surgeon, so I went the PT route. So I went to undergrad in Kansas, came back and went to PT school at NAU at their Phoenix Biomedical campus. I graduated from there in 2016. After graduating there, I got a job with Select Medical, and then working through Banner for the past. I've been with the company for 6 years now. I graduated from my orthopedic residency in 2017, and now I help out mentoring future residents for our current orthopedic residency program. And I've been here in the East Valley ever since, born and raised, and came back after Kansas.
With Dr. Neeley, how do you assess a patient's candidacy for joint replacement?
So that's a good question, and I see a lot of people that come to me and they say either one of two things. One, someone sent me to you because they say, I need to get my shoulder replaced, or, doctor, do I really need to get my shoulder replaced? And I always try to turn that back to them, because the great thing about this type of surgery is it's a quality of life surgery. And so I try to help them understand no one has to get their shoulder replaced. And you do it to improve your quality of life, especially if you failed other conservative treatments. So candidacy, textbook is typically for arthritis. We also treat patients with rotator cuff tears with shoulder replacements if they're irreparable. So the diagnosis is typically one of either osteoarthritis. We now do them for certain types of shoulder fractures as well that are not reconstructible. We do them for instability of shoulders. We do them for large rotator cuff tears. And so those are some of the different diagnoses. The other thing that's pretty interesting in terms of, I guess, candidacy is with hip and knee replacements, there are very stringent criteria in terms of BMI, hemoglobin A1C, and some of these different criteria that in shoulder surgery, it's not that we're not strict with those things, but those criteria are a little bit different because the complication rate has not been the same with hip and knee arthroplasty. So with shoulder surgery, for example, obesity with total joint replacement has not been shown to be a big risk factor for poor outcome, whereas in hip and knee arthroplasty it is. So some of those things in terms of candidacy are different. It's not that we're more flexible. It's just that patients tend to have less complications with shoulder arthroplasty. So it's a patient that, number one, has pain or instability or any of those other diagnoses we mentioned before that wants to improve their quality of life, and they've failed other treatments, other conservative treatments.
Is there anything PCP should know, before referring patients to you?
Well, so there are a lot of things that a primary care physician can do to help a patient with shoulder pain, because it's difficult to always determine what is the best surgery for a patient. Sometimes even as a surgeon, you want to choose the best surgery that's going to help that patient have the best outcome. And for a primary care physician, there are a lot of general things that they could recommend for a patient without even having to decide they need a shoulder replacement or a rotator cuff repair or whatever it is. There are some things that they could do. Specifically for patients with arthritis, there are some even over-the-counter medications that could be helpful. Turmeric has been shown to be pretty helpful for treatment of arthritis and inflammation. It's a spice. It's over-the-counter, minimal risk with that. Anti-inflammatories that you can try, and whatever your favorite variety is, I don't think there's one that's better than the other. A lot of patients do really well just with range of motion exercises, just using their joint. So I typically give patients at least some stretches they can do on their own. Cortisone injections are typically helpful for patients with shoulder pain, whether it's a rotator cuff tear or it's arthritis. And I think that's something that a lot of primary care physicians can do, or they can get comfortable doing. And it's something that we could easily spend, an hour together and, teach someone who's not comfortable. And that's something they could add to their practice, but also really help their patients. The other thing is, a lot of us orthopedic surgeons, people may not realize, but 90% of the patients I see, I don't do surgery on. And so it's okay to send someone that you think, even if you think they don't need surgery, because there's a lot of other things we can do to help them.
No, that's great. So jumping over to Jake, if a patient decides not to get a shoulder replacement surgery or a major shoulder surgery, what are some of the exercises, stretches, therapies that you would recommend for, kind of treating some of those aches and pains?
So I think if they decide to not go with the surgery and they have glenohumeral joint osteoarthritis, there's plenty of things that we can do as far as in therapy for conservative treatment. Generally, what I would say is I see two scenarios: someone that has high amounts of pain with limited mobility or lower amounts of pain with limited mobility. Generally, that's what's bringing them to the surgeon or the physician. So a person in high pain and limited mobility, generally we could use to start some modalities, ice and TENS, so to be really basic. But I'd really try to get off that as soon as possible and use that kind of to treat some of the symptoms, not treat the impairments. And then what we can do is we can do quite a bit of hands-on manual therapy. So we can do low-grade joint mobilizations to help decrease the pain, improve some of the joint glide in the glenohumeral joint. We can also implement, as Dr. Neeley was alluding to, different types of range of motion. So whether that's going to be based on the acuity of their symptoms. So if they're high irritability, we might start with low-grade joint mobilizations, work on passive range of motion, which is me moving the joint or the arm through motion, and then we can gently progress into active assisted range of motion, and then active range of motion as the patient can tolerate and the pain decreases. If the pain, especially with some of these patients, again, they might have concomitant rotator cuff issues. So if they have that and they're also painful from the rotator cuff, we want to understand, is it from the rotator cuff being painful or the joint being painful? Because we have two different avenues we can address that with. If it is a rotator cuff issue, we can start with simple exercises that are isometric in nature. There's definitely research out there to show that isometric exercises decrease pain and produce analgesia. So we can start with those and then eventually progressing into isotonic exercise, and improving the strength of the rotator cuff can improve the joint mechanics of the glenohumeral joint, especially with the compression that the rotator cuff creates when we're using the arm. So I think the biggest thing is understanding, how much pain they have, and if they have a high amount of pain, then we can implement different strategies. And if they have a lower amount of pain, we can start to implement the more aggressive strengthening exercises, the more aggressive active range of motion exercises, functional strengthening exercises. We can't change the articular cartilage, but we don't necessarily have to decrease their pain and improve their function.
Dr. Neeley, what are the major types of shoulder surgeries that you're performing?
That's something I love about shoulder surgery. There are a lot of different types of surgeries that we do. So the most common surgery that I perform is either a rotator cuff repair or a shoulder replacement. And that's either a total shoulder replacement or what we call a standard shoulder replacement or a reverse shoulder replacement. Those are also the most common diagnoses I see, rotator cuff tears and arthritis. The other somewhat common surgeries that I do are surgeries to treat problems with the bicep tendon. That is a very common diagnosis for patients with anterior shoulder pain, and that sometimes involves treating labral tears as well. I also frequently treat patients that have an unstable shoulder, which typically tends to be a little bit younger patient that you might think of more like a teenager that has an unstable shoulder, has dislocations and things like that. We also treat patients with stiff shoulders, and we do different things in the shoulder to improve their range of motion. Those are probably the most common shoulder surgeries I perform. Other things around the shoulder would be fractures. Okay, so, treating fractures of the clavicle, fractures of the shoulder itself, of the ball and socket joint. I commonly am doing fractures of the humerus bone itself or lower down towards the elbow. And as we alluded to before, I do elbow surgery as well. So treating a lot of patients with different types of elbow fractures, elbow tendonitis, elbow arthritis, or instability of the elbow joint as well. So a good variety, which I think is what makes it fun. I can do 4 or 5 surgeries in a day, and each of them is for a different diagnosis, which makes a fun day for me as well.
So Dr. Neeley, what are the 2 major types of shoulder replacement surgeries you're performing?
So there's 2 main types of shoulder replacements, and one we refer to as an anatomic shoulder replacement or a standard shoulder replacement, and the other is a reverse shoulder replacement. So you think of an anatomic shoulder replacement as, if you think of the shoulder as a ball and socket joint, we essentially place a new ball and a new socket, a metal ball and essentially a plastic socket. That is done for patients with osteoarthritis or maybe rheumatoid arthritis, but some form of arthritis of the ball and socket joint, the glenohumeral joint. And we're essentially just giving you new surfaces to articulate with. In a reverse shoulder replacement, we put the ball where the socket was, and we put the socket where the ball was. And that's why we call it a reverse. So those are the 2 main types. We do them for different indications in terms of different diagnoses, and the rehabilitation is a little bit different, and the expectations are maybe a little bit different, although that those 2 are really converging in terms of outcome.
So, and this question kind of goes to both of you. What should patients expect after a shoulder replacement surgery?
In terms of shoulder replacement, I tell them all, it's my favorite surgery to do. And the reason is patients get better very quickly. It's very different than a hip or a knee replacement, and that's because we don't walk on our hands. Okay, so shoulder, this is what I tell people is very common. I expect them most of them do it on an outpatient basis, meaning they go home the same day. Patients who are staying in the hospital overnight would be a patient maybe with cardiovascular disease, pulmonary disease, sleep apnea, or even patients with diabetes we commonly send home the same day. So most of our patients are now able to do this the same day. And actually, COVID is what really pushed that ahead very quickly, is because we were kind of forced to send a lot of patients home the same day. And as we studied it over the last couple of years, we found out that the outcomes were the same in terms of 2-year outcome, but the short-term complications were actually less for patients that were going home the same day. So I would expect a patient to have a fairly quick improvement in their pain. In terms of range of motion, this is where the two shoulder replacements might differ a little bit. So on average, you can expect your forward elevation, or your ability to lift your arm in front of your body, with a standard shoulder replacement on average is about 160 degrees about. With a reverse shoulder replacement, you're more towards 145 to maybe 150 degrees. So about a 10-degree difference on average between those two. Now, most patients don't notice that. They don't notice that difference based on their activities. So I tell all my patients, at about 3 months after reverse shoulder replacement, I'll let them go back to pretty much any activity that they are comfortable with. With a total shoulder replacement, it's a little bit slower, and the reason is for that is there is a tendon in the front of the shoulder that we detach and have to reattach, and we have to be very cautious in terms of the rehab for that. So it's closer to 4.5 months before I let them go back to everything they want. But I let them go back to golf, they can kayak, they can swim. I let them go back to any sporting activity they want. Do I have bodybuilders that go back to weightlifting? Yes. I tell them the harder they are on their shoulder, the faster it will wear out. But I won't restrict them. I don't give them a weight restriction, and I don't give them an activity restriction. So here in this area in Phoenix, a lot of my patients golf. And most of them return to golf or pickleball or tennis. But the great majority of my patients that are doing those things before or used to do those things will return to those activities. And I expect that to happen between 3 and 4.5 months, depending on their activity level. And the type of shoulder replacement really depends on your diagnoses. It depends on how good of function they have before surgery. And those are the type of conversations I have with the patient. And we really try to make it very tailored to what their goals are, what their needs are, and really what their diagnosis and anatomy is for us. But it's a great surgery. About 90 to 95% of patients rate their shoulder as excellent after shoulder surgery. So,
yeah, I think the only thing short term, in the very short term, and Dr. Neeley touched on it, you're going to have a period of immobilization in the sling that Dr. Neeley would prescribe for you. Then eventually just kind of progressively integrating activities of daily living over the next 4 to 6 weeks, doing your normal chores around the house. And sometimes that's all people want to be able to do. And it's not always recreationally based, but generally when we're looking at rehabilitation, those patients that are frustrated with how their shoulder's working do want to get back to some of those recreational things. So in general, when we're looking at rehabbing that, and as we progress through the rehabilitation process, if that's in their goals, we try to replicate that as much as possible towards the end of their discharge and into their home program, with realization that they'll continue to do those things again at that anywhere between 3 to 6 month mark, continue to progress some of those upper extremity demands as they want to produce in sport.
So one of the things that patients may ask their primary care physician is, how long do I have to be immobilized? Because that's hard for patients. Just as Jake was saying, just doing simple things like toileting, dressing, eating, simple things like that. So this is how I approach that. For a patient that has a reverse shoulder replacement, they're in a sling for 2 weeks, essentially full time. I do let them take their sling off immediately for typing, eating, anything at waist level with their hands in front of them, they can remove their sling for, as long as they don't lift more than 5 pounds. I then make them wear their sling for 2 more weeks while they're out and about. So 4 weeks total, but really just 2 weeks full-time at home. For a standard or anatomic shoulder replacement, that is also 4 weeks in a sling, but that is full-time in this sling. And we alluded to this earlier, but the reason for that is we have to detach one of the tendons to do the surgery, and we reattach it at the end. And the outcome of a total shoulder replacement is very related to that tendon healing. So that's why the sling is a little bit longer. We're much more careful in the activities we allow them to do in the early going.
Yeah, one thing I'll add to what Dr. Neeley's saying as far as, and he touched on it with the subscapularis repair, that's one thing that we're really cautious of with our rehab process, especially early in the rehab process. So when they release that subscapularis, we really limit external rotation, passive external rotation, for a period of up to 6 weeks, and then we can start to work into that range of motion just to make sure that that rotator cuff repair, that sparing, has taken tack down, and we can actually put some stress through that. And then we generally, with a total shoulder, will start isometrics in all planes, but we'll hold for the rotator cuff and the shoulder and the deltoid, but we'll hold off on internal rotation resisted activities or isometrics, just to, again, protect that subscapularis repair. And as far as one of the main differences rehab-wise is when between the total shoulder arthroplasty and the reverse total shoulder arthroplasty, where the reverse, generally it's indicated for somebody that doesn't have an intact rotator cuff. So when they come to us, they may not have external rotation strength. And when they do this rehab process, deltoid is a huge mover into flexion. So that's one of our main focuses for rehab, is really focusing, when we start, deltoid isometrics pretty early on, 2-3 weeks out. And then as we progress through the program, we're looking at, okay, can we do some modified deltoid isotonics? Are we not having any pain? Because what we want to avoid, too, is when we start to progress from isometrics into the active range of motion, that we don't cause any sort of acromial stress fracture. We don't want to go too early in that process, and we're really kind of monitoring that as we go through, because we really want deltoid to really function for that patient, because that's going to be the main mover for their shoulder, depending on how strong their rotator cuff is and how intact it is prior to surgery.
Yeah, and Jake brought up a good point a minute ago. So the subscapularis is, so there's 4 rotator cuff muscles in the shoulder. There's the one in front, which we call the subscapularis. There's one on top, and there are 2 in the back. When you do a shoulder replacement, traditionally the subscapularis is detached and reattached in some form. There have been some surgeons that have started to do this with leaving the subscapularis on, and that was one of the things that I learned in my fellowship training, was how to do a shoulder replacement leaving the subscapularis intact. And it's actually really cool, because their rehab can be a little bit faster. Their time in the sling is less, and those restrictions that we have for the rehab, we don't necessarily have to follow. Now, they still have pain early on, so we usually keep them in the sling for a couple weeks, mostly for comfort, but we're not protecting the subscapularis, which is a cool innovation. In hip and knee arthroplasty, there's robotic-assisted surgery, which I think is a cool technology to have. In shoulder surgery, we don't have that quite yet, but we're hoping within the next 12 to 18 months that will be available. And I think that will even advance the recovery more in terms of leaving the subscapularis intact, and which will, I think, really speed up the recovery process.
Dr. Neeley, you and I had a fun time talking about some of the common myths and rumors and things that we hear about shoulder replacement surgeries. Do you want to talk about some of the more common myths you've heard, and whether they're accurate or not accurate? Or
Yeah, so a lot of people have had friends who have had a shoulder or a hip or a knee replacement, and they sometimes would lump all of those into the same type of surgery, right? So, hey, my friend had their knee replaced and they said it was terrible. The recovery was long, it was so painful. And I would say a shoulder replacement is a totally different animal. So on average, my patients take pain medication, narcotic pain medication, for less than 5 days. Like I said, most of them go home the same day. And they very commonly come to their first postoperative visit, which is about 2 weeks out, and they say, I have no pain. And that's very common for me to hear. And so it's a totally different animal than a knee replacement, definitely. And it's probably closer to the ballpark of a hip replacement in terms of the ease of recovery. And don't be mistaken, it's not like this is all fun and games. It's really easy. It's a big surgery. It's a big commitment, but is it definitely a different animal than a knee replacement. The other thing that I think people have misconceptions of our range of motion. So maybe in a young laborer, they have severe osteoarthritis and they're concerned about their ability to return to work because they work overhead. They use tools overhead, they lift overhead, and they say, I had a friend or a cousin or a family member who had a shoulder surgery, and they may not know what it was, and they said, and they can't reach their arm over their head. And I would say that is very rare in patients who have a shoulder replacement. Now, there are some nuances to that, depending on their diagnoses, but the great majority of people will be able to lift their arm overhead at least 140 degrees, which is, that gives you more than enough ability to reach something out of a cupboard or lift something up overhead. And they typically would have the strength to do that. So I think that's another myth that patients have is, will they have the ability to do things up overhead if they have their shoulder replaced? Another thing is age. Am I too old to have my shoulder replaced? And age is such a relative thing these days because, not all patients who are 85 are physiologically 85. So I know we talked about this a little bit earlier, but great example. I had an 88-year-old patient in my office today. He had an acute, massive, irreparable rotator cuff tear. And I really, for a long time, tried to convince him to not have surgery for his shoulder because of his age, okay? So I kind of put him in a group and I said, you're too old to have surgery. Well, as we got to know each other better, this patient tells me he remodels houses, he rides a Harley every day, and he runs shuffleboard tournaments in his neighborhood, and he plays till 10 o'clock every night. And he was so frustrated because he couldn't lift his Sawzall and his other tools out in front of him. So he was modifying the way that he had to do that by resting his arm on a ladder, which I didn't think sounded very safe. But he was trying to modify his life, and he kept coming back and he said, I want you to replace my shoulder. And so we did. And I saw him, he's 6 weeks out today. He can already lift his arm up over his head. He's riding his Harley again. He has no pain, and he's running his shuffleboard tournaments. And I think that is very common. So age, there's no age cutoff, okay? If you're 85 and you're active and you're independent and you want to maintain your independent lifestyle, yes, you can still get your shoulder replaced and have an expectation that you will do very well. I don't know, Jake, any myths that you can think of or...
No, I think you kind of touched on. I think one of the fear is that, especially someone that you're talking about, a young laborer, is nervous that they're going to lose strength in their shoulder. It's just not the case. Generally, when you're doing a total shoulder, it's the articular cartilage in the joint. It's not the rotator cuff. So you fix the articular cartilage and you fix the joint mechanics or the joint surfaces. The strength is still there or rehabable. We can rehabilitate the strength in the shoulder and gain some of the strength that person is particularly wanting to do as far as lifting heavy weights or lifting things overhead. I think in particular, if not particularly with the joint replacement, but in the PT world, before they get the joint replacement, I think patients, and to a much lesser degree primary cares, they go based on, well, this is what my image says. It says I have osteoarthritis. I need a shoulder replacement. And I'm sure you get those patients as well. And we know from studies that just because the joint looks arthritic or there's something on an image, it doesn't always correlate with their current pain and function. So I would encourage, even if a primary care says, yeah, the joint looks arthritic, but send them to Dr. Neeley, send them to PT, and let us try to rehabilitate it prior to surgery, because we know that we can improve some rotator cuff strength if it's intact, and we can improve some of their function, because everybody's goals are different. That person may just want to reach a cup up to their cupboard, and that's an easier process than getting someone back to playing golf or recreational pickleball or something like that.
Yeah, that's a great point. So although I'm a surgeon and I enjoy doing surgery and I enjoy to see people's, improvement in their life after surgery, it's also very gratifying when you have a patient with, let's say, a very large rotator cuff tear because they fell and had a shoulder dislocation, and now they have a big rotator cuff tear and they can't lift their arm above their chest. And you maybe give them an injection to help with their pain, but they go to therapy and they'll come back a month later and they can lift their arm over their head again. And they didn't need a surgery to do that. So that is also very gratifying. And for the patient, they're very happy that they can now reach their arm over their head and they didn't have to have surgery. So I think that's a great point. There are so many things that we can treat and improve patients' life without a surgery.
I like that. I think that's a great point to hit home. I think that'll impact a lot of people, because I hear about so many patients for you guys, people that I know that are like, oh yeah, got to get the shoulder replaced. And I'm like, that seems a bit extreme.
Yeah, no, it's like I said before, 90% of the people I see we treat without surgery. And I will tell you, I talk a whole lot of people out of surgery, way more than I talk into surgery. And that's maybe because of a preconceived notion that they had, or like Jake said, they have an imaging report that sounds bad and scary. And sometimes we're just able to educate them that, having a labral tear if you're 60 years old, that's okay. And that's pretty normal. Or if you have fraying or partial tearing of your rotator cuff, that you can function very, very well with those things. And it's just, we need to get the shoulder moving. We need to restore strength and balance to the shoulder, and people can really do really well. Again, I love shoulder surgery. It's very fun, but it's also important to help patients understand that we can improve a lot of things without doing surgery on them. So,
well, do either of you gentlemen have any final thoughts you'd like to touch on? Any key points you'd like to hit?
No, I think the only thing is for patients and primary cares, don't be shy about referring over to Dr. Neeley or I. It always helps to have a second pair of eyes or a second viewpoint. Dr. Neeley's viewpoints can be different than mine, and we can work together and have some of the same viewpoints as far as principles. And again, like Dr. Neeley said, we can get patients better surgically. We can get patients better non-surgically. I think if you're ever in doubt about an orthopedic condition, always refer and get a specialist's opinion.
Yeah, one more thing I thought about was a lot of patients might ask their primary care physician. They might say, "Well, I'm, too young to have my shoulder replaced. I'll need to get it done again." Or, "How long do these things last?" So, that's a great question. Our implants get better every year, realistically, and they're lasting longer and longer. With some of our historical data, I typically tell patients for an anatomic or standard shoulder replacement, for every year you have it, there's about a 1% chance of you needing it to be redone. That's a simple way to think about it based on some of our historical data. So in 15 years, about 80 to 85% of those patients would still have the same shoulder. For the reverse shoulder replacement, we have pretty good 10 to 15 year outcome data, and it is trending in the same direction, although the durability may be actually a little bit better in terms of how long it may last with sustainable function. So I think that data continues to improve, but those are the numbers I typically tell a patient based on our historical data that we have.
Yeah, thank you gentlemen for your time.
I really appreciate you having us both on here, Jake. This has been a great opportunity for Jake and I to share something that we both love, we're passionate about in terms of taking care of patients, and for me specifically, shoulder surgery. As Jake said, please don't ever hesitate to reach out. Even if you just have a question about a patient, I'm more than happy to talk through text, email, messages through Cerner. Any way you want to contact me, I'm very available. I'm happy to answer any questions. And don't be shy again about sending a patient. If you just are uncomfortable and you just want a second opinion, as Jake said, we're very happy to see these patients. Our goal is to improve the patient's quality of life and help them achieve their goals. And in any way we can help, happy to do that. So I'm happy to be here and be part of Banner, and appreciate you having us here, Jake.